Now it is my absolute pleasure to introduce Dr. Robert A. Cain, AACOM's President and CEO, for his annual AACOM address. Dr. Cain joined the AACOM as President and CEO in July of 2019. Prior to assuming this position, he served as the Associate Dean for Clinical Education at Ohio University, AACOM, where he oversaw business development and relationship management for the clinical experiences associated with undergraduate and graduate medical education. As part of his GME-related duties, Dr. Cain functioned as the Chief Academic Officer for Ohio Centers for Osteopathic Research and Education, a statewide medical education consortium. Before this university appointment, he was the Director of Medical Education at Grandview Hospital in Dayton, Ohio, and the Director of Internal Medicine Residency Program at that same facility. Over the past 2 decades, Dr. Cain has served on a number of local, state, and national committees, task force, boards, in a variety of roles, including the American Osteopathic Association, Council on Postdoctoral Training and Institutions, the AOA Council on Postdoctoral Training, and the American College of Osteopathic Internists Board of Directors and Executive Committee. The AOA and AACOM Blue Ribbon Commission on the Osteopathic Medical Education, and the first chair of Accreditation Council of GME Osteopathic Principles Committee. He also served as president of the Association of Osteopathic Directors of Medical Educators, AODME, which is now known as AOGME. Dr. Cain was inducted into the AOGME Collegium of Fellows in 2018 and has received numerous awards for his contributions to osteopathic medical education, including the Association Osteopathic Directors of Medical Educators Leadership Award in 2014, Ohio University AACOM Master Clinical Faculty in 2011, Ohio University AACOM Medicine Standard of Excellence Award in 2009, and the American College of Osteopathic Internists Teacher of the Year in 2004. Most recently, Dr. Cain was inducted into the Gold Foundation Humanism Honor Society just earlier this year. As a specialist in pulmonary medicine, Dr. Cain graduated from OU AACOM in 1988 and operated a private practice in Ohio from 94 to 08. Originally board certified in both internal medicine and pulmonary medicine, he was recertified by the American Osteopathic Board of Internal Medicine and Pulmonary Medicine in 2018. Please join me in welcoming Dr. Cain to the stage.
We would like to be able to know that we can go to the doctor, that we can get healthy, that we can get taken care of.
I knew that something was wrong. It was easy to see. I just couldn't understand why my doctor couldn't see it.
I begged him for a CAT scan. Please do something. This is not right.
I actually had one of the doctors say that for a nurse, I seem to have a really difficult time explaining my symptoms.
Everything could be attributed to either me being dramatic, exaggerating. I thought maybe I am crazy.
I felt so alone when I was sick, and I distrusted myself.
I'm not a human to them. I'm a dollar sign.
I have a $1,100 medical bill that I have to pay, which for many Americans would be way out of reach.
You say this can't be real. I mean, I really don't have to pay this. How am I going to pay this?
We know that health outcomes are worse when people don't have access to primary care. They live shorter lives and they live sicker lives.
If we are reactive instead of proactive, that's often the difference between life and death.
The nation is more than 17,000 primary care physicians short.
Patients are not receiving adequate care, and that's just the reality.
It's all broken. It is all broken.
So good morning, everyone. And thank you, Dr. Cox, for the kind introduction. So, this is a very distinguished group. Does anyone in this room think that our healthcare system is working the way it should? Show of hands. I just want to see if there's actually any hands on. Those lights are pretty bright. I just wanted to make sure. Does anyone here think that the system we're working in is broken? Now, this may seem like a depressing way to start the morning, but I promise you it will get better. I just need to set the stage first. We can't fix something unless we recognize that it's broken. And we must be brave enough to speak the unspeakable about what we are witnessing. We know that patients aren't happy, and they're unhappy for good reason. But we aren't happy either. Few of the people in this room are satisfied. Too many of our colleagues are burned out, or at least exhausted, much of the time from the demands upon them. Depending upon the study, the United States ranks 30th in the world in terms of health outcomes. And among the 10 highest income countries, we are number 11. We didn't even make it onto the top 10 list. Where are we number one? Cost. How has it gotten to this point? Well, I would submit that part of the reason we're in this situation is that the American medical profession, and that does include us, is distracted. We're distracted by the onslaught of day-to-day realities of the work. In the mire of billing and requirements and regulations and 7-minute visits, it can be hard to remember the reason we pursued medicine in the first place: to serve the patient, to serve their families and our communities. It is easy to forget that in the broken system that surrounds us. The practice of osteopathic medicine is characterized by an ability to listen deeply, observe intently, and think big picture. If we consistently do these things, osteopathic medical education offers a mechanism to help heal this broken system. In my view, we exist to honor medicine's contract with society, or to keep it simple, what we'll refer to as the social contract. What is it, and why should we care? So this is one description. You saw it earlier in the opening video: an ethical and moral obligation to provide care to everyone while being accountable and deserving of patients' trust. We could add care based on osteopathic principles and practice, but with this group, that should go without saying. Outside of research and technical advancements, where we do well, how do you think the medical profession as a whole is doing against this promise we've made, this contract with society? So, how would you grade the House of Medicine for meeting its obligations? We should have, there we go. I'd love to see your responses. So let's see here. We've got a pretty good number in that CD category in this U.S. healthcare system. We've got some cracks in our foundation. And when it comes to the U.S. healthcare system, I'd say some of them are substantial, deep, complicated, systemic cracks. We see it everywhere, but especially in rural and underserved areas. People are waiting for long periods of time to see a physician, particularly primary care physicians, but many other critical specialties as well. And once they're there, too often, patients aren't happy with how they're being treated. Can we blame them? Look at what they're telling us. poor patient-provider communication, poor access, high cost, health disparities, the list goes on. That's the reality. But I think there are opportunities here that are unique to our mindset and osteopathic medical education. Opportunities to make a difference through the osteopathic lens. And perhaps, most importantly, we actually don't need to do anything new. What we need to do better is draw attention to the work we are already doing to attract students, teaching institutions, and communities who share our social interests, our interest in healthcare. Intrinsic values that have been part of us since our founding. Today's student who's thinking about becoming a physician is likely to be aligned to the core tenets of osteopathic medicine. These newer generations are very much interested in whole person care. And because of our growth, they're also far more likely to be aware of the DO degree. AACOM is looking to do more quantitative market research into student motivations and expectations. But I have heard clear and consistent feedback from the deans and admissions staff that the students who are attracted to our profession understand the fundamental importance of the body-mind-spirit connection to better health and to better health care. AT Still was onto something that still draws people in. Our founder took a divergent path, but it was the right one for the nation in the 19th century, and it still is. As part of Dr. Still's divergent views, he opened the door for members of society to become osteopathic physicians who were otherwise excluded, believing women and African Americans were equally deserving of a medical education. Think about how groundbreaking that was. This one man in the middle of rural America saw a better way to achieve health for all Americans. He set about to do the right thing, to do no harm, and he has left it to us to carry on. Our tradition and our roots hold as true today as they did well over 100 years ago. And I would argue they're even more important now, especially as we think about the evidence we saw a few minutes ago about the sad state of the social contract. Don't forget the responses you just gave. Students are aligned with the osteopathic profession, but I think we may be carrying on the work of AT Still a little too quietly. We need to communicate more. We must highlight the work that you are already doing to attract students and key partners in communities across this nation to our model of medical education. Consider this: 80% of healthcare happens in the largest circle, the 5,000 hospitals across America not connected to a larger academic health center. This is our space, where we have been quietly educating students and taking care of patients for more than 100 years. I say we've been quietly doing this because that's part of our tradition. Roll up our sleeves, go to work, and do the right thing. We've been quietly doing the right thing to honor medicine's contract with society for a long time. But it's not what gets attention. It doesn't get as much attention from the public, from elected officials, from funding agencies, or within the House of Medicine. And part of that is on us. There is such a thing as being humble to a fault. In my view, we have let the unique beauty and value of what we do remain unspoken, or at least too softly spoken, for too long. AACOM, with your support, is working to change that. And we've not been quiet about it. What you do in that 80% space has enormous value, and we need to call attention to it. Consider this. In the state of Michigan, if you live in a community of less than 50,000 people, your ophthalmologist is far more likely to be a DO than an MD. The same is true for your ENT physician if your community is less than 100,000 people. These communities are part of that 80% of the healthcare system we call home. We have numerous examples where colleges of osteopathic medicine are the #1 source of physicians for their state, the #1 producer of primary care physicians in their state, and the #1 producer of physicians who practice in rural areas in their state. Let's use LMU DCOM as an example. 69% of its graduates are reported to be practicing in a primary care specialty. 43% are located in underserved areas, and 23% are located specifically in Appalachia. VCOM Blacksburg and Spartanburg also continue to see more than 60% of their graduates enter practice in a rural or medically underserved area. Importantly, a quarter of VCOM students come from communities of less than 10,000 people, which is a predictor of where they're going to return to practice. In fact, 64% choose to practice in the regions of VCOM's mission. Our colleges are in the right places, over the full spectrum of urban, suburban, and rural, and doing the right things, like selecting students with interests in primary care, educating them in community locations, and teaching to competencies needed to practice in rural settings. There are so many ways that osteopathic medical education is helping to keep the promise, is honoring the social contract, especially in primary care, rural care, and physician placement. And most importantly, in how we treat our patients. But we can't do it alone. This past year, we have pushed a far more aggressive legislative agenda than ever before. Most of you are familiar with the FAIR Act. The FAIR Act has caused a bit of a stir among some of our MD colleagues, but it has been worth it on many levels. The idea is simple. If your GME program receives Medicare dollars, you cannot discriminate against osteopathic medical students and residents simply because they carry the DO degree. That shouldn't be groundbreaking, but it is. Collaborating with the AOA and MBOME, our approaches on the legislative and licensure fronts have caused people to pay attention and to begin to express support for change. We spoke the unspeakable about bias against our community, and people are listening. More recently, we have secured significant bipartisan support to expand access to community-based training for medical students in rural and medically underserved areas. The Community Training, Education, and Access to Medical Students, or Community Teams Act, is so appropriately worded because it is specifically about grants to fund what you are doing in towns and cities, large and small. In other words, support for the areas where healthcare most happens. The vision driving these efforts is pretty clear. These words are taken from our board-approved opportunity statement. I want to focus on that last word, communities, because I've been thinking about it a lot this past year. We work in a model that focuses on communities who need us most. We draw from areas of need, train in areas of need, and retain in areas of need. Hence, a community-based training model. Who says, based upon the numbers I shared earlier, we can't solve the primary care shortage in this country? Osteopathic medical education is proving day in and day out that it can be done. If we could replicate across the House of Medicine what DO programs and many of the newer community-based MD programs are doing and incentivize these choices appropriately, we could solve this problem. But it will require the value of the community-based training model to be reflected in American medical culture, our policies, and our funding mechanisms. We need to create the right conditions to succeed. One way for us to do that is to be more explicit in defining value. So let's create a top 10 list of what OME can deliver. Improve patient satisfaction, enhance treatment adherence, reduced healthcare utilization, positive effect on chronic disease management, stress reduction and improved mental health, effective pain management through OMT, improvements in student and physician burnout, positive health behavior change, reduced health disparities, healthier American communities. Isn't this what everybody wants? To sum up how we get these results, the tangible values of holistic and patient-centered approach that we deliver in osteopathic medicine include more comprehensive treatment, preventive care, individualized care plans, enhanced patient-physician relationships, recognition of the body-mind-spirit connection, the use of OMT, patient empowerment, health promotion, and long-term health benefits. Almost sounds like a path towards healing our fractured system, doesn't it? The core aspects of what you are teaching and what DOs do contribute to a more holistic and personalized healthcare experience for individuals. It isn't new to us. It isn't a new government or third-party mandate for payment. It's been part of us for over a century. And patients are telling us that's exactly what they need and what they want. The people in this room have the answers to many of the most difficult and long-term healthcare problems we face in this country, and it's time you're recognized for it. Not for our own benefit, not for the good of our organizations or the guild, but for what it means for patients. It's important to note that while there is a growing body of evidence supporting these outcomes, research in the field is ongoing, and that is something AACOM is paying close attention to as we work to increase funding through the NIH and other agencies, and as we partner with funders inside our own community, like the Osteopathic Heritage Foundations. 6 months from now, with support from the OHF, we will convene a national summit specifically to address the value of osteopathic medicine and identify strategic priorities for osteopathic medical education and research. We will bring together the nation's leading research and OME experts to lay out a framework for the future of our profession in these two key areas. As part of the summit, we will develop language that helps describe and quantify the value we bring to the healthcare system, what we offer that is otherwise lost or difficult to replace without our community. Most allopathic medical schools gain attention due to the research conducted by their partnering academic health centers. That research is valuable, but the results often feed right back into the narrative that there is only one way of thinking about medicine. It's time we write our own narrative in our own space. A few more highlights, also with support from the OHF. We worked with the Uniformed Services University of Health Sciences, or USUS, for the past 18 months to complete an important study on osteopathic recognition. What we learned is that osteopathic recognition and continued osteopathic training at the graduate level is valued, yet there are several challenges that may be preventing many historically osteopathic programs from applying or participating. It will take innovation and action from the larger OME community to break down these barriers. The work of the UME-GME Task Force has also been in full swing, releasing a residency readiness bootcamp playbook, a toolkit for students re-entering the residency match, and tools to help students navigate resources on the transition to residency. At this conference alone, there are 8 programs featuring the work of more than 100 volunteers from across the OME community who serve on this task force, and thank you for that service. We have been able to put significant resources into this type of new programming and services due to strong internal fiscal discipline and because of a historic investment from the COMs into our organization. As part of our AACOM 2030 project, we have been able to bring new talent and skill sets into the organization to keep pace with the evolving needs of the COMs and enable us to lead in areas we've not had a voice in before. It takes all of us to move our profession forward. And with the support of our members, we have built stronger relationships with key partners, including AOA, COCA, and MBOME. Outside of the osteopathic family, we have been participating much more deliberately in joint activities with AAMC, AMA, ACGME, NRMP, and others to move our issues forward. We are having tough conversations within the larger House of Medicine because we need everyone to understand that our students shouldn't have to perform better than their colleagues just to have equal opportunities. Let me say that again. Our students shouldn't have to perform better than their colleagues just to have equal opportunities. Part of that work is to acknowledge and address the very real burnout and challenges to well-being facing our students. The bad news is that 10% of our incoming students report they are already burned out, and almost 30% report psychological symptoms of depression and even suicidal ideation. By graduation, more than half of our graduates report these same symptoms, more than half. Under a $2.2 million grant from the Health Resources and Services Administration and partnering with 10 of our COMs, we found that we can do something about it. We can make a difference in those statistics by developing a growth mindset, purpose and relevance, and sense of belonging for our students. All of these approaches can have a measurable impact and improve well-being. So there is hope, and that is good news. A lot has happened and is happening that should make us proud. But we know we can't do everything all at once. So to focus our work and make sure resources are going exactly where we need them, the executive team met earlier this year, and we made some hard choices about priorities. We selected 3 for the near term: leadership, applications, and community-based medical education. Leadership. Show it, know it, grow it. We are showing our leadership in a number of areas, but one I am particularly excited about is working with the U.S. Department of Health and Human Services on nutrition as proactive, preventive healthcare, specifically their Food is Medicine program. We are hosting an OHF-sponsored program here at the conference tomorrow on food as medicine, and will produce a statement of commitment from our community as a tangible outcome. We are doing this because we want this part of whole person care to be influenced by an osteopathic voice, one that has recognized the importance of determinants of health for over a century. As our colleagues do a bit of catching up here to the health-oriented concepts we've been talking about for a decade, we want to be in a leading role. We are knowing leadership by working to increase the number of people completing leadership training offered by AACOM and growing it by adding new programs, like the Train the Trainer hands-on workshop for osteopathic preceptors that reteaches faculty about OMM and prepares them to teach it to others. We actually piloted this on Tuesday here in Kansas City, and I hope that it will be replicated across our member institutions. Priority 2, applications. We have heard loud and clear that the OME community and COMs in particular are very concerned about the changing environment surrounding applications and applicants. Even if COMs are seeing great application numbers, finding the right applicants and making sure they accept and matriculate has become more complicated. especially as we see class sizes grow at established comms and the increase in the number of new comms. A major commitment in our strategic plan is to reimagine recruitment and admissions, and we have spent months working with Cameo leaders, our deans, and others to introduce a portfolio of new products, tools, and services to support new approaches to marketing, data-driven recruitment, and the use of AI to promote a more holistic admissions process. And priority 3, back to community-based medical education. What it offers now and what it could offer if we can shift attention to that 80% of healthcare that we are directly involved in the places that others aren't as willing to go. Let's look at a pilot project in Scranton, Pennsylvania, that addresses the challenges many comms are having, especially securing adequate clinical experiences and preceptors and building long-term relationships with community health systems. Importantly, this idea came from community leaders. The Northeast Pennsylvania Education Collaborative, comprised of comms, healthcare facilities, and the broader community, is testing the idea that smaller towns can solve their own healthcare problems. Problems in Scranton that stem from a 23% poverty rate, opioid addiction, chronic disease, poor oral health, among other things. This is what it looks like today. In the current system, the health plan and regional or national health system serve as the trunk of the tree you see, often keeping medical education, research, and other features only if the return on investment is high enough. This has led to the many faults we find in our current system: inadequate and costly access, an emphasis on expensive tech-heavy treatments, and a medical education system that turns out specialists that meet the needs of the systems, that meet the system's fiscal needs as its first priority. Sound familiar? It isn't very focused on the patient, or the patient's family, or the community. But the vision of the Scranton Project flips that model to what you see here. The trunk is now the community, defining its needs. There's an emphasis on primary care with access to specialists. And physicians serve as community leaders who are promoting ongoing support, not just for healthcare, but for public health, education, and other institutions vital to all members of the community. Who says this can't be done? And then replicated in modified versions in towns just like Scranton all across the United States. Towns that many of us in our roles at our colleges have called home for a very long time. Osteopathic medical education is exploring and creating viable solutions to strengthen the community-based model of medical education and demonstrating its values in places that need it most. You are already helping to meet the promise of medicine's contract with society, and it's high time we celebrate that. But right now, the community-based model of education is not well understood. We need a more predictable structure with enough commonalities that people outside our community can understand it and appreciate its value. If we can do that, imagine the possibilities. Through research and publication, descriptions for those who don't understand. Imagine if we better organized the environment in which we are operating and found ways to direct greater resources and funding into that overlooked and underserved 80% of our healthcare system. Imagine the appreciation. When you can see that structure, it makes sense. The beauty of the model is understandable, and as a result, its value is clearer. I started out this speech by acknowledging the work that needs to be done by us, by our allopathic colleagues, and across the health professions to fill in the cracks in the foundational commitment we have to our society. For me, this event is one of those spaces where we can have these discussions and perhaps speed the healing process. This Educating Leaders is one of the highlights of my year and has been since I started in this role in 2019. Seeing this type of a crowd is truly humbling. And for the second year in a row, this is the largest attendance at an AACOM annual conference in our history. It's wonderful to see so many of our colleagues in one space who have a shared commitment to our principles. We have even been joined this year by an international colleague, the president of the Pan American Federation of Associations of Medical Schools, a group that represents more than 600 medical schools in the Western Hemisphere. He is here today to learn more about our community. While we know that the challenges we face are serious and we must acknowledge them, we also need to take a moment to honor what we do and the positive difference it's making in this world.
The first time sitting down with that osteopathic physician, it was just a different experience.
He sat there, we talked for a while, he was asking me questions, he was jotting things down.
She was always very supportive of me finding things that fit in my lifestyle.
She thought of me as a person, as a wife, a mother, everything.
He did not have just 5 minutes to give me, but he really wanted to sit there and learn about me as a patient.
I immediately knew that I was cared for and that I was going to be cared for well.
That definitely changed my perspective of just that doctor-patient relationship.
Having that kind of relationship to where I can be honest and it's encouraged to be honest, it means the world.
I can be comfortable with them. I can express to them what's going on. And to me, that right there alone is what sets a DO aside.
When you get to know these DOs and how they are dealing with mind, body, and spirit, it's just such a joy to see them.
What DOs do for the body, it's just amazing. I love it.
They inspect and then they palpate, they actually touch.
They are amazing with what they do with their hands, the way they allow the body to treat itself.
I believe so much in what they're doing.
They are all very personable, down-to-earth people who just love caring for others. I am blown away by their compassion.
It elevates people back to where they should be.
They encourage us every day to make the best of what we have.
When you do find yourself in that time where you need a physician that you do feel comfortable, you're saying to yourself, I need a DO.
They're closing a huge gap in accessibility, and that means a lot for the citizens of those communities.
If it wasn't for them, I'd probably be curled up in a ball in my bed. And that may be a large part of why the relationship is so important to me, because my life depends on them.
Becoming familiar with osteopathic medicine, I realized that that is something that I wanted to do for the rest of my life. I wanted to practice osteopathic medicine.
It has completely changed my outlook on what medicine can be.
They were such a part of my life and a reason why I'm still here, and I'll be grateful to them for eternity.
We have been so happy, and our last 20 years have been such good health providers that we're amazed.
They're really just making the world a better place.
So I'm going to go a bit off script for a moment. You know, as you sit here, physicians, faculty, other members of the community, you're not only members of that teaching community, you're patients too. And at some level, you experience the things that we've talked about here today. And for me, this has been a really personal experience, having to deal with some serious issues over the past year. When I saw that picture yesterday that the child had drawn. And I don't want to disparage at all my MD colleagues. That's not the point of these comments, because we have to appreciate each other and we have to complement each other and work together. But I could draw that picture for almost every specialist I've seen in the past year. Looking at the data, back to you, barely engaging with you, rarely shaking a hand or touching you in any way. I had to find a new primary care physician. All my care was back in Ohio, and as a result of needing to move things to Maryland, had to find a new internist. So I went looking for one of your grads. I will not tell you which school. I wanted to do that, but I will not do it. Was seen initially for a pre-procedure evaluation, great visit, great individual. But it was the follow-up one that was important. Because it was him sitting on a stool, shaking my hand, eyes looking at me, and asking how I was. That really mattered. So you teach our students that fractures only heal under the right conditions, and that wounds close if cared for the right way. To start to create the right conditions for healing in the U.S. healthcare system, we need to say it out loud that it is broken and that we can do better. And we need to say it even louder that osteopathic medical education and osteopathic care can provide real answers to some of the most troubling healthcare problems facing this country. My amazing team, whom I thank for everything we do, and I look forward to continuing to tell the story and to shining the light on the important work you are doing every day in your communities. Thank you for giving me the opportunity to be in this role and to share some of my thoughts with you. And I hope they lead to deeper shared commitment among all of us and increased action from this community. And importantly, thank you for what you're doing every day to help speed the health and healing we so desperately need in this country. Please enjoy the rest of the conference, and thank you for joining me this morning.